Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chi Manchu, and I'm joined tonight by my co-hosts, my friends Sam Mazer and producer Hartley Litsky. Hey guys.
Hello.
Hey Chris.
Tonight our guest is Dr. Rida Hasan to discuss pediatric transfusion medicine. But first, Sam, do you want to remind us what this show is all about?
I'd love to. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation tonight with our guest, Dr. Rida Hasan. Dr. Hasan is board certified in both pediatric hematology and transfusion medicine. And when she's not busy trying to keep up with her Mocha Peds questions, she spends her time either at the blood bank at University of Washington or seeing benign hematology patients at Seattle Children's Hospital. She loves being able to bridge the gap between the laboratory and the clinical side of pediatric transfusion medicine. She knows this topic feels foreign to practicing pediatricians, but tonight she teaches us that the type and the screen are two different things. She teaches us what a six-pack is and how to stop a transfusion reaction in its tracks.
All right, guys, time to delve into this bloodstream of knowledge.
Ooh, all right, not bad.
We can totally transfuse some clarity into this complex topic.
All right. Yeah, keep going.
Afterwards, we can cross-match our discussion points.
Oh, there we go. I like that one. Yeah.
All right, there we go. We can circulate through today's topic. Dr. Hasan, thank you for coming on the show. But first, because we're an informal group, is it okay if we call you by your first name?
Yeah, that would be great. I prefer my first name.
Excellent. So, since you're new to our show, could you help our listeners to get to know you a little better? Give us a couple sentences about yourself and maybe something that you like to do that's not medical.
Okay, yeah. So I am a pediatrician who turned into a hematologist and then turned into a blood banker. There's very few of me out there, but I have now met more than a handful of us. So we started off thinking we're going to do pediatrics, and now we're the head of a blood bank somewhere. Most of us don't do any clinical time. I still do a little bit. And then outside of medicine, I will say that I am not at all an outdoorsy person, and I'm originally from the East Coast, and I like to stay indoors, but now I live in the Pacific Northwest, and it is absolutely beautiful. Last year, I skied for the first time. I started hiking a few years ago, and I have real hiking poles. So don't ever say you're not an outdoors person, because you never know. Things might change.
Yeah, I think I'm ready to move to Washington now. It just seems so easy to get outside and go do some fun things.
Yeah, it's amazing how much time I want to spend outdoors, especially when it's like the nicer months.
Oh, that's wonderful. All right, so I think we have a really loaded, big episode for us today. Should we just get into it?
Whether this is your first episode or you've been listening to us since day one, you know our goal has always been to share clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine. So let's talk about something that actually changed my day-to-day as a pediatrician: figs. I can't walk into a clinic or hospital without seeing people in fig scrubs. And I get it. I wear them too. They're incredibly soft, form-fitting, and durable. And it's not just us. If you've been watching a certain popular ER drama on TV, yep, they're in figs too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids and kids come with messes, I love that figs are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine 50 plus times and they still look brand new. All of that and so much more is why we've teamed up with Figs. Now Cribsiders listeners can get 15% off. Just go to wearfigs.com and use code FIGSRX. That's wearfigs.com and use code FIGSRX for 15% off.
All right, Hartley, why don't you take it away?
Let's do it. So Today you're working in the Kashlak Children's Emergency Room when the pediatric trauma alert sounds and a motor vehicle crash is arriving to the emergency room, including our 8-year-old patient, Rida. In the ED, she is alert but definitely in pain, and the POCUS raises concern for intra-abdominal bleeding. So while you're calling surgery, you're monitoring her vitals, and she's becoming unstable. So her rapid hemoglobin value and her type and screen is still pending, but you are thinking about initiating a massive transfusion protocol for an emergent blood transfusion. So let's start from the beginning. Maybe in this situation, maybe in other situations, what labs do we typically need to order before we can do a blood transfusion?
So you should definitely order a CBC if you can to make sure your patient is anemic and needs transfusion. And then the other test that we need from the blood bank side is a type and screen.
What is a type and screen?
That's a great question because I think colloquially people just say type and screen, but no one actually knows what it means if you ask people. So they're actually two separate tests. So the type is when we determine what antigens you express on your red cells. Are you blood type A? Are you blood type B? Are you blood type O? And then we also do RH, so are you RHD positive or negative? So that's where you hear, oh, I'm O positive. And that's only off the type. And then the screen is the one that people don't really think about. And that actually looks for the presence of red cell alloantibodies. So this is not anti-A and anti-B that we know you're going to make naturally if you're depending on your blood type. These are the screen we expect to be negative, so you shouldn't have any alloantibodies. But in patients who have been alloimmunized, either pregnancy, transfusion, transplant, they can sometimes make a red cell alloantibody against the minor red cell antigen. And I don't want to say minor means that they're not significant because they are significant. Some of them can cause big issues with transfusion, but I mean more so like the anti-Cal, Duffy, those blood groups that you sometimes see if you are taking care of a complex patient population.
So, Hartley said type and screen, but I often hear type and cross as well. Is that the same thing? Is that different? What's the difference?
Yeah, a type and cross is different. And I will say when we were doing paper orders, a type and cross is probably more like when a lot of medicine was on paper and we weren't able to do things electronically, it's probably more relevant. Now, a lot of blood banks have actually built the type and cross order or the cross part of it into when you order a unit of red cells. So what it means is that it tells the blood bank, okay, I want you to determine my patient's blood type, also determine the screen, even though that you're not saying that, and then also get a unit of blood ready for them specifically. So dedicate this unit in your blood bank for our patient Rida. Now, what happens is that when a physician puts in an order for a unit of red cells, there's two parts to the order that say one is prepare and one is transfuse. And that essentially tells us the same thing as a cross that, hey, I'm going to transfuse my patient. I want you to get a unit of blood ready. And then when the nurse is ready, that's when she'll release to send the unit up to the floor. So in our system, at least, I can say that you actually, when you search type and cross, we'll just have it in parentheses, type and screens. So people don't think that they're ordering a different test because all we're going to do is your type and screen. And then when you actually order the unit saying, okay, now my patient needs 2 units of red cells, the cross part is embedded telling us, okay, we have to cross match. And we are required to cross match. Every red cell unit that we hand out to a patient has to be cross matched. So that's kind of already implied.
Gotcha. It's bonkers that no one has ever explained this to me. So how long does it actually take for a type and screen versus a type and cross or preparing a unit of blood cells?
So doing the actual type and screen testing, like I said, there are 2 different tests. So the blood type actually doesn't take too long. It takes about 10 minutes. Because a lot of those antibodies that we're looking for are IgM, so they have spontaneous agglutination. The tech just adds it to the patient's plasma or the patient's red cells, and we see agglutination right away, and we know, okay, this is their blood type. The The antibody screen actually takes an hour because those antibodies are IgGs. So now you're talking about monomers. You're not going to get spontaneous agglutination right away. And also they don't like to react at cold temperature. So now we have to heat up the whole sample to 37 degrees body temperature for at least half an hour. And we have to add an Hg reagent anti-human globulin to enhance any agglutination so we can actually visually see whether or not there's agglutination. So the screen takes an hour, but the blood type takes 10 minutes. And then depending on if your screen is positive or negative, getting a unit ready could take like not even a minute. If your screen is negative, we don't do anything fancy. We just say, oh, the computer can tell us based on the blood type, and the tech should know what ABO types are going to be compatible with your patient. But if the screen is positive, then we have to do the actual classic thinking that you think about a cross-match, where we take the patient's plasma and then the red cells from the unit, and we actually mix them together, and we see is there going to be agglutination or not to tell us whether or not it's compatible. So that's only relevant for a patient with a positive with a positive screen. And that can actually take an additional hour to do that cross match, because it has to be, again, looking for IgGs, again, has to be warmed up. So that can take up to a 2-hour process if your patient has a positive screen. And if your patient actually has an antibody against a lot of different red cell antigens, or against like an antigen that's present in most of the population, and like less than 0.1% of the population is actually negative for that antigen, then it takes us a long time to find the blood. So for some of our patients who have really complex alloantibodies, it can actually take us days to get even 1 unit of red cells in our inventory that we can cross-match for them. So it really just depends on the patient. Most patients, I'd say an hour to 2 hours, we should be able to do a type and cross, or type and screen and then cross-match a unit. And then some patients, it could take days.
And is any of this machine automated, or is this all via a tech kind of taking a look under the microscope?
Yeah, thankfully, it is not all manual. We moved away from that. So there's these big machines that do our type and screens actually automated. Machines are only so smart, though. So if anything flags as being positive, then we move to having a tech do it manually. So in our lab, we have a automated bench where it's all the automated machines, and I still have not 100% of the concept of what happens inside the machine, but we load the samples and it just takes it for an hour, and you get these beautiful results and visuals. But if anything is flagged as being positive, it can only take you so far. And now you're looking for, the screen is positive. Now you have to do it all manually. And then we have a manual bench where the techs are able to do that.
Gotcha. I mean, one of the reasons why I was going to ask is, we have ourselves doing these type and screens every 3 days. And if you have these patients doing this every 3 days and you got all these techs doing it, I'd be like, man, that's actually a lot of manual labor. But right now it sounds like we can at least put it in a machine until something else pops up. So why are we doing these type and screens every 3 days?
Yeah. And the providers always like to ask us this. They're like, do we have to do it every 3 days? So it's a great question. Obviously, your patient's blood type is not going to change, right? So you're a patient with leukemia who is admitted, who's blood type A positive and is getting initiation chemo, is still going to be blood type A positive a week later. So we're not expecting their blood type to change. And a lot of people don't realize that it's actually not the blood type we're focused on, it's on the screen. So patients who are continuously getting exposed either through pregnancy or transfusion, or in rare cases, transplant, bone marrow transplant, those are the patients whose screen is going to change because they're being exposed to other red cell antigens. And it's kind of a balance. Like, we could do a screen every day, but obviously clinicians will not be happy with that. The patients will not be happy with that. But that will actually increase our risk of increase our ability to find patients whose screens turn positive. But I think 3 days is a compromise where, it's limiting the amount of testing we're doing, but we're also able to screen patients and find that they develop alloantibodies. And we do find that there are patients who have been in the hospital for a while who are getting transfusions, who all of a sudden went from a negative screen to a positive screen. So it does happen pretty frequently not frequently, but it happens that, patients go from a negative screen to a positive screen in the same hospital stay. We do offer something called an extended type and screen, and I think this is a concept that's becoming more and more common in different hospitals. So if you have a pediatric patient who's getting a TNA in the outpatient setting, this is a healthy patient, not getting transfusions, obviously not getting transplanted, not pregnant. You know their type and screen, the screen's not going to change to being positive. So does that patient really need to wait till the day of his operation to get that type and screen performed and potentially delay the timing of the surgery? Or from his pre-op visit a month ago at surgery where they're doing their entire H&P, could they just draw a sample at that time? And could that be good for the day of the surgery? So we do have exceptions where we call it an extended type and screen. And our hospital does this specifically where for up to 30 days, specifically in this patient population that's not sick, that's not like hospitalized, that's outpatient coming in for a planned procedure, we'll accept samples within the last 30 days, as long as they haven't been transfused, pregnant, or transplanted, and the clinician who's ordering it has to confirm that at the time that they order it, and also at the time that they release the order, and we ask the units to be released, nothing has changed in the patient's status.
That makes perfect sense. So in the hospital, when things are evolving more quickly, we need that rapid turnover. But outpatient, it's possible that we can wait a little bit longer because we don't expect the screen to change.
Exactly. And some people could argue, do you need to do it make that rule for every single person in the hospital? We probably don't. There's patients who obviously have not gotten transfused, but for us to figure out who was transfused, who wasn't transfused, every time we see an order come in, it would just be way too complicated. So it just makes it easier to just make it a blanket statement for those inpatients that it has to be every 3 days.
If you've ever listened to a heart murmur and thought, did I really hear that? You're not alone. I've had moments in the wards where I thought I caught something subtle, maybe a faint gallop or an irregular rhythm, but with background noise, a restless patient, and no time for a second opinion, I just had to move on. That's where Echo Health came in. Being able to record the sound meant I could revisit it later. And with the help of Echo's AI, I got confirmation that what I heard wasn't just in my head. It's like having a second set of expert ears, even after you've left the room. So Echo combines the stethoscope you already know with enhanced audio and advanced AI to help you detect heart and lung conditions earlier and with more confidence. With Echo, you can hear with precision, even in noisy environments. Their digital stethoscope amplifies heart and lung sounds up to 40 times, and noise cancellation cuts out distractions. You can also detect disease earlier, unlock murmur and AFib detection powered by Echo AI, along with sound recording, sharing, and more for earlier diagnoses and seamless collaborations. And lastly, it improves diagnostic accuracy. Backed by millions of heart sounds and 8 FDA clearances for devices and AI algorithms, clinical studies show that those who use Echo are 2 times more likely to detect heart disease. And a personal benefit? Teaching. I've used Echo recordings to walk learners through abnormal heart and lung sounds, and even to help patients better understand what's going on with their own bodies. It turns the stethoscope from a black box into a real-time teaching tool. So we trust Echo so much that we worked with their team to create a special offer just for our listeners. Right now, you can get up to $50 off, plus a free customizable chest piece cover at echohealth.com/Cribsiders. Your purchase may be HSA and FSA eligible and may also qualify for CME reimbursement. Plus, Echo guarantees you'll detect heart and lung conditions more confidently. And if you don't, return it for a full refund. So again, go to echohealth.com/Cribsiders for up to $50 off, plus a free chest piece cover. That's ekohealth.com/Cribsiders.
So in this situation, the team wanted to call a massive transfusion protocol. Can you talk about how that's different from a regular transfusion?
Yeah. So when you think about the priorities for a blood bank, what we want to know is how quickly do you need the blood? Can you wait an hour? Can you wait 4 hours? Or do you need it within 10 minutes, within 5 to 10 minutes? So massive transfusion protocol tells us that, hey, I can't wait an hour. My patient is bleeding. I need the blood now. I need it. And there is actually like specific criteria that they have, like you need more than a certain number of red cells within 24 hours. But I feel like, how is that helpful in that acute bleeding setting? And so what you need to do if my patient is bleeding and they are hemodynamically unstable because of the bleeding and they need a transfusion right away, and you activate what we call a massive transfusion protocol. So that tells us I need the blood quickly. I need it within 10 minutes. So if we don't have time to run the screen, then that's totally fine. I need that blood before that screen results. That's where we might give what we call uncross-matched units if we don't have the screen performed by that time. And then the other thing it tells us is that my patient is bleeding a lot. And back in the day, when your patient would bleed, you say, oh, they need red blood cells, right? But if they're bleeding, let's say like 500 mLs or 600 mLs in the OR setting, are they losing just red cells? What do you think?
No, probably not.
No.
Yeah, but
No,
all people
whole
are
blood.
thinking about bleeding, so they're just giving red cells. So actually, what happens is that people tended to only replace red cells, and now you made your patient coagulopathic because you didn't give them back their platelets, you didn't give them back their plasma. So now your patient is more coagulopathic and they're going to bleed more. And then you give more red cells because they're bleeding, of course. And then it becomes like this vicious cycle where you're trying to fix your patient, but you can't because you're not thinking, oh, they're actually coagulopathic. So an MTP, every hospital has a requirement to have what we call an MTP pack. And what you get in an MTP pack actually can vary from hospital to hospital. All it is that it says that I'm going to give red cells and plasma in a specific ratio. So you don't ask to even have to think about ordering plasma. You just say, I need an MTP pack. And at our hospital, we give 4 units of red cells and 4 units of plasma. Some hospitals, our trauma hospital, our sister trauma hospital, they give 6 units of red cells, 6 units of plasma, 1 unit of platelets, and 2 units of cryo. So it's all a little bit different depending on where you are. In the pediatric hospital at Seattle Children's, we do it by weight. So depending on if you're over 30 kilos or under 30 kilos, we'll give 1 unit versus 2 units. But the whole idea is that you're giving red cells to plasma in some kind of ratio up front. And the clinicians are not having to like place different orders through Epic. And then you're giving what we call balanced resuscitation, where you are giving coags along with red cells up front.
So, I think this is a good opportunity just to step a little bit to the side of talking about, all right, massive transfusion protocol, and kind of talk a little bit about each of these components. Talk about red cells, talk about platelets, talk about maybe even cryo or plasma. Talk about a little bit about what transfusion is. Maybe we can talk about indications that we can save for a different day, just because that's more the clinical focus from that standpoint, but more like, what is a transfusion of red cells for a kid? How is that dosed? When do we generally, that type of thing. And then we can talk about what's in the red cells, what's in plasma, what's in cryo, what's in platelets, and kind of the nomenclature behind it, if that's okay. I know that's a lot of stuff, but maybe we can just start with the red cells and then I can kind of keep cueing us and we can make our way through.
Okay. Yeah, no, I think that's great. People, I think red cells is the most straightforward because that's the product that most people are familiar with ordering. I know when I was a pediatric resident, I was like, oh, red cells, I can do this. So red cells, the indication, you give red cells to increase oxygen carrying capacity. So in patients who have anemia. And then the other indication you give it is bleeding patients, right? They're anemic, but it's due to like acute bleeding. So their hemoglobin might be 10, but they're actively hemorrhaging. So you want to transfuse them. Or versus an oncology patient who's getting chemotherapy and their hemoglobin's 6.5. So you might transfuse them for a hemoglobin less than 7. And then in pediatrics, we dose red cells based on weight, and that's about 10 to 15 mLs per kilogram. I will say it gets a little bit tricky because once your patients get to like 30 kilos, a unit of red cells is about 300 mLs. It ranges. It's about like 300, 250, 300. But once you get to 300 mLs, why would we actually measure out specific mLs? You're basically at a unit would be fine. So at Seattle Children's, we do like a weight-based. So if their patient is under like 30 kilos, they order in mLs. And if they're over 30 kilos, then you just get a unit. And that kind of helps minimize the work from the blood bank. So we're not trying to figure out what 460 mLs is for an adolescent size patient. And we're able to get units quickly to the provider that are appropriate for the patient size. Is there anything else about red cells that you wanted to?
Just one other question. We often talk about aliquots, and maybe we can talk about this in transfusion reactions later on, but why would someone say, oh, I'm going to give, a hematologist says, hey, you should give 10 milliliters per kilo, but give it in two 5 milliliters per kilo. Like, does that come up a lot? And that's probably my only question about red cells.
Yeah, I will say probably the only people who do that are pediatric hematologists.
Yeah, right.
And we do it in patients who have like a severe chronic anemia. So the classic patient would be a toddler, like a 2-year-old with severe iron deficiency anemia who's coming in for a hemoglobin of 3. And you obviously, this is something that's chronic because the toddler is running around the room completely fine. And their heart has gotten used to actually operating at a hemoglobin of 3 because of how chronic it was. So your worry is that if you transfuse them too much fluid too fast and they don't need it, and their heart is actually accustomed to 3 mLs per kilo or whatever, 3 grams per deciliter for their hemoglobin, then you might cause actually overload. Something we call TACO, which is just transfusion-associated circulatory overload, which is basically a form of heart failure that's started by a transfusion. So you worry that you're going to volume overload them, possibly cause a transfusion reaction such as a TACO, and that can have its own adverse side effects and actually make the patients more sick. So you want to transfuse, quote unquote, slowly. So there's a couple of ways to do that. So you can give, instead of 10 mLs per kilo in one time, and it's over 4 hours. So instead of giving 10 mLs per kilo over 4 hours, you could do 5 mLs per kilo over 4 hours, and then do another 5 mLs per kilo over 4 hours. That's a long time for him to be hooked up to an IV pole, but it's slow and it's safer for the patient in that indication. And that's the most common indication where we might do something like that.
Perfect. Absolutely perfect. Maybe we'll jump to, what do you guys think? Platelets? Does that seem like a...
Yeah. I want to so when it comes to platelets, I hear this thing called like a 6-pack of platelets, and all I can think of is like a 6-pack of beer. And I don't really understand like why don't we look at platelets like units or like in milliliters or I guess we do, but I just never understood like how do they all relate to each other?
Yeah, and that's actually really interesting because I think we have moved away from that. So originally, the only way that we could collect platelets was when people went in and gave a whole blood donation. So this is where you walk into a blood drive and they collect, 20 minutes, they collect a unit from each person that's there. And then what you do is you spin down that whole blood into different components. And for platelets, you don't get a ton of platelets out of that. So that's nowhere near enough to transfuse an adult. So what we would do is we actually would pool 6 different donors together. So we would pool the platelets from 6 different donors, which is what we call a 6-pack, to create one big unit of platelets that would be an appropriate size to transfuse an adult patient. Yeah, so that's what that refers to. And it's more, and then in pediatrics, we could technically, we obviously are not transfusing the whole unit to a pediatric patient. So potentially they could get like a single unit, as you're calling a single pack, versus you might have a big one that you're actually just aliquoting different syringes off of. So it just varies depending on what inventory you have. I will say right now, most places, at least in the US, have moved towards getting apheresis platelets. So we're no longer, most of our inventory is actually not the way that I described previously, where the 6-pack came into play. It's actually now a donor comes in and they go to the donor center and they're hooked up to an apheresis machine for about 2 hours where all that's collected is platelets. So they're not donating red blood cells, they're not donating plasma. The machine only targets collecting platelets, and you can get 2 to 3 units from one single donor. So that is the primary way that platelets are collected currently. So that's why that 6-pack actually is no longer relevant, because now we're getting one full apheresis unit, which is equal to that 6 pool donor unit that we were getting before. But every once in a while, we do have a confused resident or someone who just hasn't ordered blood in a couple of years and who asks us for 6 units of platelets. And we're like, wow, this person is asking for 6 like big apheresis platelets for this patient. And we know exactly what they're thinking. So we have a conversation and usually it's pretty easy after that.
So how many platelets are in a single, like a unit of platelets then? How many platelets would you expect in there?
So there's a minimum requirement. It's 3 times 10 to the 11th platelets per unit. Usually it's well over that. I cannot tell you how many zeros there are, whatever that comes out to, but that is an actually requirement that each unit has to have 3 times 10 to the 11th for an apheresis platelet. It's a little bit different for a 6 pooled platelet. It's a little bit lower. It's like 5.5 times 10 to the 10th. And I know this because I had to memorize it for my boards. But so it is a little bit lower yield for a pooled platelet. But yeah, like I said, pooled platelets, essentially, there were a lot of regulations that came out with platelets because there was a higher risk of bacterial contamination with them. So because of that, a lot of places phased out pooled platelets because of like all the testing regulations and requirements. But now we're kind of in a place where we're having platelet shortages because how many people actually go in and donate apheresis platelets? So how many people actually do that? Not
Chris,
a
the
lot.
two-man chew.
Yeah, so my wife, she's an O negative, and back when we lived in Annapolis, they always asked her to come donate. So I would always go in with her, and then they're like, well, we really need platelets. So they always had me do platelets, and she would give her O neg blood. And so I'd be sitting there forever, and they'd spin down my blood. And I was always wondering, like, so we don't have to like type in screen platelets, correct?
So platelets have to be ABO compatible, but not the screen is not relevant because they're not expressing red cell antigen. So the screen is really for red cell allo antibodies. But the type is relevant because platelets are suspended in plasma, and your plasma is where you have anti-A and anti-B. So you do have to worry a little bit about plasma compatibility. I will say because there's shortages in platelets, a lot of people will not account for that because you might only have 2 units of platelets in your blood bank. And we know that the risks of giving ABO incompatible platelets is actually very, very low. In pediatric patients, we do try to be more stringent and actually look for ABO compatible platelets, but yeah, it just depends on the hospital and what your inventory looks like. But thank you for donating. I really appreciate that you were able to take that time, but a lot of people are not. So my goal was to say that actually pooled platelets might be making a comeback. So that 6-pack might become relevant again. So stay tuned. But when, at least us, the way that we have our orders built in, we try to say you should just be ordering 1 unit with the assumption that this is a 6-pack pooled platelet or like a full apheresis platelet.
And then kind of getting back a little bit to the dose, again, per kilo, where we kind of end up, what is that volume? And so what should we be dosing that for a child compared to when we switch to an adult weight?
Yes. So for children, platelet is about 5 to 10 mLs per kilo for a rise in your platelet count of about 30 to 50,000 is what we recommend. And then again, that weight cutoff, we kind of keep it the same. I think it might be a little bit lower for platelets, but like around like 25, 30 kilos, we say just order a full unit.
And actually, you made a good point about increasing the number of platelets, or at least the count up to 50,000 increase in your platelets. We kind of just assumed, but what is the increase for the hemoglobin with the packed reds?
Yeah. So it's in hemoglobin, it's about like 1 to 2 grams per deciliter for 10 to 15 mLs per kilo.
Okay. Awesome. We should remember to ask that about the next pieces that we keep asking, so we know not only what we're doing, but also where it's going to get us. So if we need to order 2 or 3 or 4 different quote unquote units, depending on your size. Awesome. Anyone else have any other questions about platelets? Otherwise, I wanted to jump to plasma.
Yeah, we need to do the other parts.
Yeah, let's hit plasma, and then we'll hit cryo, and then we'll keep moving. So now that we're jumping onto plasma, let's start again with the indications, and then we'll kind of walk our way through the size of each quote unquote unit and what it increases after that.
Okay, yeah. So plasma, you give when your patient is coagulopathic. So it's a trauma patient, so they're coagulopathic because they have they're because of their trauma, or it's a patient who has an infection and they're in DIC. That's kind of the most common settings where we see it ordered. People usually measure coagulopathy with INR or PTT prolongation. And plasma has essentially, if you think about it, there's your red cells, and then your plasma has all of your good coag factors. So all of your coagulation factors are in there. In pediatrics, we do it based on weight. And it's, again, I always remember the magic number is 10 in pediatrics. So it's 10 to 15 mLs per kilo for plasma dosing, very similar to hemoglobin. And then again, if you're over, let's say, like 30 kilos, so you're requiring more than 300 mLs of plasma, then we say just order in units at that point. And then essentially, we say that 1 ml per kilo is going to increase your factors by 1%. So if you're ordering 10 to 15 mLs per kilo, then your factors are going to increase by 10 to 15%. That's how we see that.
I do have one question. Let me know if this is true or not, but I actually heard that plasma has an INR of 1.5, so you technically can't get lower than 1.5 with your INR after giving fresh frozen plasma.
Yeah, that is a great question because that comes up a lot, and I know a lot of people want an INR less than 1.5 before procedures. So if you think about a healthy donor, that's where our plasma is coming from. Most people don't actually have an INR of 1, which we think would be a perfect INR. Most people actually have an INR of like maybe 1.2, 1.3. So that's something to keep in mind. And then what we really want people to focus on is that the curve for what percentage of your coagulation factors you have and what your INR is actually not a linear curve. It's a logarithmic graph. So an INR of 1 might be like 100% coagulation factors. An INR of 1.5 is 40% of your coagulation factors. And an INR of 3 is maybe like 15% of your coagulation factors.
Oh.
So the benefit that you get with each transfusion is actually better the higher your INR is. So if your patient has an INR of 4, a unit of plasma might get them to an INR of 2. But once they get to an INR of less than 2, the benefit that you're going to get, you might go from like 2 to like 1.8 after a unit, 1.8 to like 1.7. And then when you really get close to like 1.5, 1.4, where your donors are running, now you're essentially just giving them almost the same INR they already have. So there's always, there's a really great graph that's out there called like the zone of normal hemostasis. So what people have to understand is that you don't need 100% of your coagulation factors not to bleed. And actually over 30% of your coagulation factors is enough to not have any bleeding symptoms. And I always remember that like when we diagnose hemophilia, there's mild, moderate, and severe, and mild is less than 30%. So you don't need to have 100% factor VIII to not have a bleeding phenotype. And that's important to remember that when you are giving plasma, you're not trying to get your patient to an INR of 1 and 100% coagulation factors. You're probably trying to get them closer to an INR of like 2, which is about 30% of coagulation factors, a little less than 2. And that should be enough to prevent any kind of bleeding and coagulopathy.
And that adds up perfectly. You know, you were mentioning, hey, 1 milliliter per kilo is about 1%, you know, giving 10, that's about 10%. So you're really only increasing by 10% each quote unquote unit that you're giving. And so therefore the idea of getting beyond 30% past that, or you could have even been starting at 15% at that time, you give 1 unit, you kind of get to that 30 range, kind of goes below, you know, an INR of 2 when you're kind of good is what I feel like we're hearing.
Yeah, and a lot of, and I know that there's been a lot of work mostly on the adult side, but like with interventional radiology, the societies to really get their INR thresholds from 1.5 to 2, and trying to work to realize that an INR of 1 is just going to result in overtransfusion and very little benefit to the patient.
One question I have is we've been saying plasma a lot now, and I don't know if the last time I've actually ordered plasma. Often I order FFP, fresh frozen plasma, in the hospital. Is that the same thing or is it different?
So there's actually a lot of different kinds of plasma. So if you think about There's I don't want to get into it, but essentially has to do with how long it took you to freeze your plasma. So if you froze it within 8 hours versus you froze it within 24 hours, there is different terminology. So it actually gets very complicated. So it's going to be kind of crazy to say, but actually most of your plasma is not fresh frozen plasma, which is frozen within 24 hours. It's FP24, which is plasma that's been frozen. Fresh frozen plasma is frozen within 8 hours. And then most of your plasma that you're probably getting is what we call PF24, which is plasma frozen within 24 hours of phlebotomy from apheresis collection. And there are little nuances, but it has to do with the fact that some of the factors the longer you take to freeze your plasma, it decreases. So really like factor 5, factor 8, you can kind of get a little bit decrease if you really compare your plasma that was frozen within 8 hours, quote unquote, fresh frozen plasma versus PF24, which is frozen within 24 hours. And there's actually a couple of other ones that are out there I'm not going to get into. But really it's from the blood banking side. And I think, for a patient who's bleeding where you're trying to get that increased, that coagulation factors to be greater than 30%, it's probably not relevant for that indication.
Chris, before you get on to the next question, because I know you got a good one about another product there. We didn't fully say this out loud, so I just wanted to say it. What's in plasma? Coagulation factors for sure. Mm-hmm. What else is in plasma that we should know?
So there's antibodies in plasma. So when we give plasma, we have to account for, so when antibodies, we talk about anti-A and anti-B, because obviously your donor is not going to have red cell antibodies. They should be healthy. But we have to account for that ABO compatibility component when we pick a unit for a patient.
Okay.
Yeah.
Awesome.
So as we're looking at plasma, which has a bunch of these coagulation factors in it, there's another blood product that that I've used more recently, and I was wondering if you could talk about this. So we call this 4-factor PCC, or 4-factor prothrombin complex concentrate. I had to look up how to say that, by the way. What are the 4 factors in there, and why is this better than plasma? And I'm sure it must be better for some reasons.
Yeah. So 4-factor PCC is factor 2, 7, 9, and 10. So your vitamin K dependent factors. And some might say, oh, why would you give this versus plasma to a patient? So plasma is going to have factors 2, 7, 9, and 10, but it's also going to have all of your other coagulation factors in there too. But it's really volume. So for 4-factor PCC, the volume is a lot less versus giving plasma, which is 250 mLs. 4-factor PCC is a small vial. It's basically a medication that you give to the patient. So volume is a huge component. And this is interesting because for warfarin reversal, for the longest time, plasma used to be what you would use for warfarin reversal because those patients are depleted. Their vitamin K dependent factors are not working. And actually, there was a study several years ago that now Kcentra is first line for those patients for warfarin reversal. But if you don't have Kcentra, then you do. Then now you do plasma. So.
Awesome. Yeah, I mean, I remember back when I was in residency, we didn't have 4-factor PCC at the time. We only had like a 3-factor PCC in the US, and I kept on seeing all these studies about 4-factor PCC in Europe, and I was happy the day we got 4-factor PCC. I'm sorry, I didn't mean to derail that talk.
No, this is great. Should we move on to the last one before we start talking about? And the last one's going to be cryoprecipitate. We should at least talk about that. How the dose is, again, indications, dose, and what else is what's in this product that we should know about.
Yeah, I would love to talk about cryo because I think that is where providers get very confused. So cryoprecipitate, a lot of people don't know, how is that different than plasma? So it's actually made from plasma. So I'm going to just put that out there. So what we do is we've taken whole blood, we've spun it down, we took the plasma and we froze it into FFP. And now we're going to take that FFP and we're going to thaw it and freeze it again. That's a lot of work. But what that does is when you go through this rapid freeze thaw cycle is all the heavy coagulation factors will settle down to the bottom of your plasma now. So what are your heavier coagulation factors? So the biggest things that we think about are factor 8, factor 13, and fibrinogen. Those are the big ones that are going to settle down. So cryo is made from plasma, but it only has your factor 8, factor 13, and fibrinogen concentrated into it. And what that means is that you really only give it for those indications. So if your patient has general coagulopathy, DIC, rapid consumption of all of their coagulation factors, then you don't give cryo, you should give plasma. However, if your patient is in DIC and you know that their fibrinogen is less than 100, and you want to replete the fibrinogen specifically, you should give cryo. And cryo is another one where people get confused about the packs because you can only get so much cryo from each donor. So we often end up pooling 5 donors together and we create a cryo pool. And that sometimes gets confusing in the pediatric setting because we actually will have like individual units available and we'll also have a cryo pool available. So especially in the NICU, it can get a little bit confusing to providers what they should be ordering if they're not used to it. But cryo, the biggest indication to give it now is low fibrinogen. Factor 8 and factor 13, we now have factor 8 and factor 13 that's available that you can order. And that's much better and much higher doses and much smaller volume than giving cryo. So that's recommended for hemophilia in patients with factor 13 deficiency. And cryo is really the biggest indication is hyperfibrinogenemia. And we expect that dose of cryo is about 2 to 5 mLs per kilogram or 1 unit per 10 kilos. And that's going to increase your fibrinogen about 100 to 150 milligrams per deciliter. Those are really hard numbers to put together. So there is actually a formula that's out there. I think it's available on online where you can just click in your patient's fibrinogen and their weight, and it'll help you calculate how many units to order for individual units.
Awesome. I think we're ready to now talk about what happens when these products go into someone's body. Do you guys think so?
Yeah, we should start transfusing it.
Okay, yeah, cool. So, but this is perfect, right? Because we have all of we know most of the products we're going to transfuse. There's probably some out there that I still don't understand, but at least the ones that we talked about, we got. So let's kind of walk through a little bit about some of the things we have to do to these products. So as a blood banker for yourself, are there any special considerations you have for these products for specific patient populations that we need to know about?
Since this is a pediatric podcast, I'll focus on what we do for pediatrics first and neonates. So for neonates, there's a lot of things that we worry about. One is obviously volume. So we're very careful about volume. Most places will have orders based on weight versus if you have adults or adolescents that are over a certain weight, then you'll just say order in units. And that's very specific to pediatrics. And then the other thing that we really worry about is potassium content. So we do know, we didn't talk about shelf life, but let's say a unit of red cells can actually sit on our shelf for 42 days. But we do know that the longer that unit sits on the shelf, the more potassium that leaks out of those red cells. So it's probably not relevant to an adult patient, but now you're talking NICU, these babies, or a baby getting like an exchange transfusion in the NICU. And now it is relevant because it's a high volume transfusion or your child's really small. So we try to use what we call fresher units. So units that are less than 7 days old, specifically for our neonates. Another thing that we worry about is CMV transmission. So before we used to have like CMV negative donors versus CMV positive donors. And a lot of people would ask for CMV negative, obviously for their NICU or for their oncology patients. But now that we have leuker reduction, we basically have, once products are leuker reduced, they're called quote unquote CMV safe. So the risk of CMV transmission is also almost 0%. So all pediatric products should be leuker reduced. And then for our NICU specifically, we worry about could they have an undiagnosed immunodeficiency, or maybe they have like DiGeorge syndrome and we don't know yet because they haven't presented. So we do something called irradiating for children that are less than 4 months old. We also do this for our oncology population. I will say for NICU specifically, this kind of providers get a little bit confused about this because, we'll off the cord blood, we'll do the baby's ABO type, but we almost always only issue type O blood to the NICU population. And that's because no matter what the cord blood shows, and that's because we know mom has passive antibodies, right? So mom has anti-A and anti-B that could be IgG in nature. Unlikely, but could be, especially if mom is type O. So we don't know what antibodies have passed into the baby. And then the other thing is the baby's not really making their own anti-A and anti-B yet. So they're not really producing antibodies for the first 4 to 6 months. So when we do their blood type, we can't make a full assessment of exactly what their blood type is. So we tend to give them type O no matter what the cord blood shows. I can talk more about other populations too.
Before we get that, you use two terms, irradiation and leukoreduction. Can you explain those a little bit? I think I have an idea what irradiation means, but if you could explain what that process is and what does leukoreduction actually mean as well?
Yeah, I will say I used to get those two confused because I was like, how are they different from each other? And then people often get confused, like what you would do for one versus another. So leukoreduction is actually a filter. So it's a very physical manual process where at the time of collection, you basically put the whole blood through a filter. And this filter attracts white cells, so it removes them from your product. It's not 100% removal. You can still have a small percentage of white cells that are allowed to remain. But basically, because you're removing white cells, you're decreasing your mechanism for having anything that can transmit CMV. So leukoreduction makes the product CMV safe. And also because you're reducing your number of white cells, you're decreasing the risk of febrile non-hemolytic transfusion reactions too. That's another thing we found when we started leukoreducing. Right now, leukoreduction happens at the time of collection. And I will say that most products are actually leukoreduced. Yeah, most of your products, you can pretty much assume they're leukoreduced. Irradiation is not something that's done routinely for everyone. So irradiation is not manual. Now we're thinking about, okay, we went through the filter, we removed like 99% of our white cells, but we still have 5 times 10 to the 6. So you can still have like a million white cells remaining in that product. And you're thinking, okay, these could be lymphocytes. And if these lymphocytes, my patient does not have an immune system of their own, these lymphocytes are just going to continue to replicate without anything to fight back. So this is really like our oncology population who's getting very heavy chemotherapy that specifically targets their T cells. We're thinking about our neonates, our patients with T cell immunodeficiencies. They just don't have T lymphocytes that are going to fight back against these donor lymphocytes, and these donor lymphocytes are going to be able to replicate. And this is going to cause something called transfusion-associated graft versus host disease, which has a really high mortality rate. So irradiation, what it does is that you put your unit into an irradiator, which delivers gamma radiation or X-ray radiation that zaps your lymphocytes, so that way they can't replicate. So whatever lymphocytes are in that unit cannot replicate any longer. And now when you transfuse it to that patient who doesn't have a T cell immune system, it's not going to cause any issues. So we only do irradiation for very specific populations. It adds cost, it's labor. It also decreases the shelf life of your products. But yeah, and leukoreduction, you think of kind of being done universally to almost everything.
Just about that irradiation piece, it seems like it definitely has costs if you don't have an irradiator in your institution. If you have a irradiator, I don't know if it just looks like a giant microwave, but if you have one, is there any downside to just be like, all right, I'm just going to zap it for a minute, before putting it into everyone's body, or is there something else that I'm missing? I'm just curious about that.
Yeah. So we don't have to irradiate anything that's been frozen. So I do want to put that out there because the freeze thaw process will actually inactivate your lymphocytes. So FFP cryo does not have to be radiated. So really, we're just talking about platelets and we're talking about red cells. I will say it does increase the time. So we try not to irradiate until, especially for pediatrics, neonates, we actually try not to irradiate until the time that we know it's going to be transfused. And it's because, remember I was saying that red cells leak potassium. When you irradiate it, that actually increases exponentially. So it happens a lot faster. So we like to do what we call freshly irradiated units for our pediatric NICU population. So we'll usually take those 10 minutes at the time that you ask for the unit to radiate at that time. So it will increase your time to delivery. It also decreases the shelf life because we do know it's going to increase the rate at which potassium accumulates. Now, a red cell that you could have kept on your shelf for 42 days is only going to be good for 28 days. And in a place where we have a lot of shortages, it's really hard to maintain inventory, even with 42-day shelf life of red cells. So trying to maintain it at 28 days, now you're making it even harder for the blood bank. So that is the downside. And we do have an on-site irradiator. And I will say a lot of like big pediatric hospitals probably do, again, because they do want those freshly irradiated units.
Yeah. So realistically, someone's going to tell me what to transfuse, but I do actually have to go talk to the patient about the transfusion and their parents. And so I would love if you could talk through sort of your process on counseling families and consenting families on the risks and benefits of blood transfusions.
Yeah, thank you for asking this question, because I remember being that PGY1 pediatric resident trying to get blood consent, and I was like, I don't know what to say. Like, I know there's a risk of transfusion transmitted diseases, but that was pretty much like all I had, plus what was written on the blood consent form. So I will say my biggest advice too is to actually look at your blood consent form before you consent a patient and get familiar with what's written on there, because parents will read it and they will ask you specific information. And some places are very detailed and they'll actually list like your percentages of like risk of transmission transmitted diseases and risk of reactions, and other places are not. So you should know what's on your consent form when you end up starting your internship or before you consent someone. The way that I approach a transfusion consent now that I'm a transfusion attending is that I start with the benefits. And with the benefits, I really talk about what is the indication for the transfusion, because they need to know, why are they getting a transfusion? Is this patient having surgery and they're potentially could bleed and become hypovolemic and unstable? That's why I would transfuse. Or is this a hemonc patient who has anemia because of chemotherapy, and transfusion is to help with a little bit with their quality of life and their oxygen carrying capacity? So indication is different. And even within the same hospital stay, if your patient has surgery and then they get admitted for a complication, the indication can actually change. So always rediscuss. Don't just look and say, oh, there was a consent when the patient came in. If the consent happened in the setting of surgery and now you're giving a transfusion for another reason, make sure you have that discussion with the patient. What is the benefit of the transfusion for them? And then the second part I think about is the risks. And risks, I don't tell the family every risk that's going to be out there, because that's going to scare them and they're going to ask a lot of questions, and they're already, especially parents, they're already very worried about their child, and you don't want to increase their anxiety level. What you want to counsel them on is the fact that there are risks. The two big things we think about are transfusion reactions, and then the other risk is transfusion transmitted diseases. So for transfusion reactions, I tell them that when the patient is being transfused, the nurses are actually checking the patient very closely, monitoring their vitals. And then we also ask you that if you notice that something is wrong, the first thing we would do is actually stop the transfusion. And parents want to hear that. They want to know that their child's going to be monitored, and something looks like they're going wrong, then you're going to stop the transfusion and we would do an assessment. And I say most reactions are actually sometimes it's bad enough that we're not able to complete a transfusion, and most reactions are mild and we can support it with medications, and sometimes there are dangerous ones, but those are extremely rare. And then the second thing we do is, in terms of transfusion transmitted diseases, is I talk to them about the fact that there's 3 ways that we try to make the blood supply safe. The first way is that we try to use a voluntary donor pool. Although I will give the caveat that as we get more and more shortages, we might be moving away from that. But right now, a lot of places use mostly a voluntary donor pool. So patient has no incentive to donate except the fact that they want to donate. And that means that for the second thing, the donor questionnaire, they're going to be completely honest because they have no incentive to lie. So the donor questionnaire asks, will be a way that we screen out patients who are donors who should not be donating because they are higher risk for some of these infections. And then the third thing we do is that every individual unit is tested for a certain set of diseases. And the most common ones that we think about are hepatitis B, hepatitis C, and HIV. So every single unit, despite what they said on the questionnaire or that it was a voluntary donation is still going to be tested to make sure it's negative for these diseases. And there's a couple of other diseases that they test for.
Amazing. That's awesome. That was super helpful. So you mentioned the risk of transfusion reactions. I'd love if you could talk sort of for us as clinicians who aren't specialists in transfusion medicine, what are some things that we can do to set a patient up for success and avoid transfusion reactions if at all possible?
So I think I can talk about some of the mitigation strategies we have for these reactions. So the first and the most scary one is, oh no, your patient got the wrong blood type and we gave them the wrong unit. So that's an acute hemolytic transfusion reaction. And the way that we decrease the risk of that is that over time, we have moved towards a lot of two verifiers. So every blood sample that's collected for a type and screen actually needs two people to verify, hey, this came from this patient. So we make sure that it wasn't mislabeled. And then the other thing is at the time of the transfusion, two people have to verify the unit before it's transfused to the patient. That has decreased the risk of acute hemolytic transfusion reaction significantly because most of these errors were occurring at bedside because of mislabeling. The second transfusion reaction is a delayed hemolytic transfusion reaction. So this is your patient has red cell antibodies and they react to those minor antigens. We mitigate by doing a screen every 3 days. Remember, you guys asked, why do you need to do a type and screen every 3 days? That's why, because we don't want your patient to have a delayed hemolytic reaction. Febrile non-hemolytic transfusion reactions is with leukoreduction. So we decrease the amount of white cells, so there's less cytokines in the product, less risk of having that reaction. Patients that have allergic reactions, this is a little bit of a complex category because a lot of people will have mild allergic reactions where we'll do nothing because most patients actually won't have a recurrent one. But for patients who have severe anaphylactic allergic reactions where they needed epi and it was life-threatening, we can actually wash their products to remove like 99% of the plasma that's in the product. If your patient has transfusion-associated circulatory overload or TACO, we can volume reduce their platelets, specifically also their red cells, where we decrease the amount of mLs that are in the unit without decreasing the yield too much. For transfusion-associated graft versus host disease, this is where the lymphocytes from the donor activate in the patient and basically attack the patient's immune system. We do that by irradiation for specific populations. Trolley, so this is something where you have transfusion-related acute lung injury. It looks like ARDS following a transfusion in a patient. This one is a little interesting because it's due to the donor actually having human neutrophil or HLA antibodies in their plasma. So the donor is actually alloimmunized. And we've determined that by having components come from male donors, because never been pregnant, so pregnancy tends to be an alloimmunizing event. So having basically plasma components come from male-only donors or females who have been tested for these specific HLA, HNA antibodies, you can actually decrease the risk of trolley. And that's a weird one, so they like to test for that.
And then I'm curious, so we do everything we can to mitigate the risk of transfusions, right? We talked about all the things we do. Mm-hmm. But what happens if someone has a blood transfusion reaction? I imagine the first thing we do, as you mentioned earlier, we stop the transfusion. Mm-hmm. Is there anything else we can or should be doing for this? Now, if this is too complicated, like each individual thing has a different response to it, then I will kind of leave that for later. But I'm just curious if it's like universally, like, look, just stop the transfusion reaction and then supportive care your way through.
Yeah, we do have requirements that everyone has to do. So I will say that if it's like an allergic transfusion reaction, it's not as strict, but for any like fever or respiratory symptoms or anything allergic reaction that's more than just skin only, we say stop the transfusion. So absolutely you should stop the transfusion. Call the provider, check the patient, then call the provider. And then the nurses at bedside should do a clerical check because unfortunately, a lot of these errors that lead to acute hemolytic do occur at the bedside. So did I transfuse the right unit to the right patient? And then what they do is they also collect what we call a post-transfusion sample on the patient. So this is another sample kind of like for a type and screen that they send to the blood bank along with the unit. So in most situations, once the patient has a transfusion reaction, they're not completing that entire transfusion. You're giving the unit back to the blood bank. On the blood bank side, we also will do a clerical check to make sure that did we give the right unit to the right patient? Maybe we mislabeled it, something happened on our end. And then with the sample that was given from the patient, we spin it down and we do what we call a hemolysis check. So this is basically looking for free hemoglobin in the plasma. Is your plasma red or is it clear? So basically, we're looking for complement-mediated hemolysis that would be found in the setting of an acute hemolytic transfusion reaction. We also repeat the AVO type. So maybe all the samples we got on this patient were all from the wrong patient, and we thought the patient was A positive, but they're actually not. They're type B. So we actually repeat it on that post-transfusion sample and make sure it matches what we have on our records. And then the third test that we do is called a DAT, a direct antiglobulin test, also known as a Coombs test, where we're looking for now the presence of antibodies. So we're seeing, is this an immune-mediated transfusion reaction? And that kind of helps us figure out which pathway we're going to go down.
And are there any medicines that we should be giving as well during this, or again, stopping the transfusion reaction and then whatever we need to do to hemodynamically support the patient until they get better?
Yeah, I would say based on the patient's reaction, you should be supporting them, like you said, to stabilize them. So if they're hypotensive, give them boluses. If they look septic, give them antibiotics. Give them Tylenol if they have fever. But yeah, there's nothing like that we would specifically recommend.
No antidote to transfusion, or something.
Nothing we could avoid. There's things we can avoid going forward.
Yeah.
So if someone is having like volume overload, then going forward, we can do things like I talked about. But in that moment, unfortunately, it's already a done deal. And that's true also for the hemolytic reaction. So let's say someone does have an acute hemolytic. It's kind of already a done deal. There's nothing we can do to reverse it. It is just supportive care.
And actually, one more question. So this just happened to me last week. This is the reason why I say it. I had a patient who started getting a blood transfusion and became hypotensive. He actually didn't have a skin rash, but seemed like, allergic in that component. Could have been on his way to an anaphylaxis, whatever it may have been. So we stopped the transfusion. And then they also wanted the blood bank asked for the urine sample as well. So I'm curious why you would also want a urine sample.
So they're looking for hemoglobinuria, so red urine without red cells present in it. And that would be, again, a sign of complement-mediated hemolysis if you had an acute hemolytic reaction. And we actually don't require that, but there are places that do require that in their transfusion reaction workup. I think we used to, and then we were having very poor compliance with it.
Gotcha. I'm also sure I wonder if the sensitivity is relatively poor in that test as well to go along with what else you're getting, but who knows?
Yes. I think the hemolysis check is also looking for it, and that's a requirement, so we feel pretty good. But some places will require a UA. That's a great point.
So my question is, I feel like there are some patients who require just a little bit more thought behind their blood transfusion strategy. I mean, maybe patients who've had a lot of transfusions or something else. I guess my question is, as a resident, who should I call and talk to the transfusion attending about? Which diagnoses, which patients need that close collaboration with transfusion medicine?
Yeah, that is a great question because a lot of people will say, I didn't know there was someone that I could talk to on the transfusion side when I was a pediatric resident. So there is someone there. Patients that we want you to call us about are basically patients with complex transfusion needs for sure. So if you have a patient that has red cell antibodies and you're about to transfuse them, or maybe you're seeing them in your clinic for the first time and it's a patient with sickle cell disease, they're coming from somewhere else with this really complex history, we want you to call us. Patients that are going to have a positive screen and why. So if they have alloantibodies or maybe they have a warm autoimmune hemolytic anemia, those are also patients that you could always give us a heads up about. So when we're looking at the workup, we're not scratching our heads. We actually have some information that can help us guide the workup so that our results can be faster to support your patient. Patients that have a history of severe transfusion reactions like anaphylactic allergic reactions where you're asking for something like washed products or you're worried they might have a recurrent one, call us about those patients. The other call we often get is patients who are platelet refractory. So I didn't get into this, but you can also make alloantibodies against platelets. So if your patient is not responding to platelet transfusions and are not getting an appropriate bump, you can call the blood bank about that to evaluate for that and do the appropriate testing. And then the other population is patients that just need a lot of transfusions. So if they're going to have a planned surgery and you think you're going to need like 6 units of red cells up front, or like 4 units of platelets because they have a platelet disorder, then those are all units that you can call us about so we can make sure that they're available for the patient. And we can also maintain our inventory. So if you're in a smaller hospital and you know your patient's going to have a large transfusion need and it might make a big strain on the inventory, it's always good to have a heads up so we can order more units for other patients.
That's super helpful. Okay. I will start talking to my transfusion medicine attendings. So I'm curious, you mentioned earlier, I think a little bit about blood shortages and sort of how we maintain inventory and where blood comes from. I want to get into that, but I also want to know if there's any disparities that we see specifically for racial or ethnic minorities that make it more challenging to find safe blood for patients from specific backgrounds.
Yeah, so unfortunately, this is something that we're seeing a lot of right now. So I'll talk about the ethnic disparities first. So most of our donor pool is Caucasian, and what red cell antigens you express, even ABO, like what your breakoff is in terms of what percentage are type O versus type A, actually kind of depends on your ethnicity. And then whether or not you're Rh positive or negative is also impacted by that. So someone who's Asian, like 99% of those people are actually Rh positive, versus Caucasian, it's 85% are Rh positive. So it actually does make a big difference. And I'm not even getting into the minor blood groups where it's even more disparate from ethnic group to ethnic group. So what happens is that when we're giving our units that are mostly a Caucasian donor pool to patients who are not Caucasian, we're actually exposing them to minor red cell antigens that they potentially don't express. And that increases their risk of alloimmunization against red blood cells, specific red cell antigens. So the best example for this is our patients with sickle cell disease. So a lot of these patients are Black or African American descent, and they don't express the same antigens. We know that they don't as the Caucasians. So they actually have a very high risk of developing alloantibodies to antigens that are found on these donor units. And the other thing is that they're going to get a lot of transfusion. So that also increases their transfusion burden and their risk of alloimmunization. So we try a lot to decrease their risk of alloimmunization, and it's like up to 30 to 50% of these patients will develop alloantibodies. So we've come a long way in terms of trying to match for certain antigens up front. So before the patient even makes the antibody, we actually will give what we call antigen matched units to Rh and Cal. And this has decreased it, but it hasn't made it 0% or 1% like the general population. It's still pretty high rates of alloimmunization. So that's one of the things that we're continuing to look at is how do we decrease the risk of alloimmunization? And people have done research, if you bring donors who are also from a similar ethnic background, will you decrease the rates of alloimmunization? And that research actually hasn't been as straightforward as we wanted it to.
It sounds like just in general, we should have a call to arms for everyone to donate more platelets, regardless of your background, just because we have shortages everywhere. I guess one question I have is in general, like us as primary care physicians, frontline, like how should we be talking to our patients about donating blood? Like we're in the middle of like 10,000 other things, but I feel like this is really, really important. And if so, like how do you think we should broach that topic with our friends, our family, with our patients?
That's a great suggestion, talking to your patients and families about that. I don't know the best way to go about it, I'll be honest, especially because your patients are very sick. Parents are obviously very stressed. And I usually find that it's when the patient gets better, that's when parents are maybe in a mindset where they are able to think about, like, how can I give back to the community? My child in the NICU received so many transfusions. Now that they're out of the NICU and they came through this, that's kind of the time for them to reflect on what helped the child and how they can what they can do to help for children in the future. So it is a little bit of a sensitive topic. I think during blood shortages, we try our best to not alarm patients. I know we tell physicians, and then we try to send like hospital-based communication or have epic banners or something that tells you that there's a shortage. We try our best to not alarm patients and tell them there's no blood. But I think those are also times that we could potentially talk about limiting transfusions. And then if parents ask, why are you not transfusing my patient? His hemoglobin is less than 7, and that's our standard for oncology patients. You could say that actually right now there's a little bit of a shortage. So until he's symptomatic or maybe he's a little bit lower, we're going to wait till our inventory is a little bit better. And that might be a time where parents are willing to donate.
Excellent. And of course, like we ourselves should, if we have time, we should be donating ourselves, right?
Yeah, I was gonna say, physicians, we don't have the time, but we actually do. If I think you do it, right? You donate platelets. So if you know you're type O neg, go donate red cells. If you're AB, go donate plasma, go donate platelets. Those are all very helpful. And then encourage others to donate. And obviously, every product helps along the way. It's going to benefit someone.
And is there anything we should know about blood donations as far as, we all just assume it's the American Red Cross and go find your closest, blood mobile. But is there something that we should actually know about donation centers, or some more available than we think? Is it not just the Red Cross or other places that we should go? How do these hospitals get stuff? Just if we're trying to support a hospital, how do we actually go about doing that?
Yeah. So I think it's good to know what your donation center is, what you have access to. The Red Cross, I think, has footprint in a lot of different states, but a lot of hospitals actually will collect some hospitals, bigger hospitals will actually have their own blood donation on site. So you can actually go into the hospital and donate blood, and they can actually use those units you donate to make units and transfuse to the patients. So that's a great place to do it. And then there's also some smaller regional companies that are out there here in the Pacific Northwest. So we have Bloodworks Northwest. There's also another group in Texas. So there's also some other smaller regional companies, not the American Red Cross, that also have that also collect blood and will give it to hospitals. I will say that blood drives used to be a really great way where people could donate. It was easy. You would have one at work. You could just show up. Since COVID, the number of blood drives has decreased significantly. So they were shut down for many years. And now we're still not back to 100% of where we were, especially in high schools, which was a good percentage of our donations actually came from high schools that would host blood drives 1 to 4 times a year. And now we're still not back to having that level of robust blood drives. So you might find that your opportunities to just walk onto a random blood drive is going to be less and less, and you're having to actually seek out opportunities where you're contacting your donor centers and seeing and scheduling an appointment and making specific time out to schedule and donate.
I will say at my institution, if you bring 3 friends with you, they buy you a pizza while you sit in the hospital and you donate your blood.
Nice.
That sounds like a great deal.
Pizza party. Party.
Yeah.
All right.
Med student pizza party.
So I want to thank you for enlightening us, because I definitely learned a lot. Maybe things I probably should have learned a long time ago, but I really appreciate it. I'm very sure that our listeners learned a lot too. Do you have any main take-home points for listeners before we sign off?
Yeah, I will say that I want you to take away what I didn't know when I was a pediatric resident or even a hem-onc fellow, is that if you're transfusing a patient, there's a blood bank on site somewhere in the hospital. And if there's a blood bank on site, then there is a medical director of the blood bank that's on call 24/7, even if you're on nights. And even if they're not there in person, they are on call and they're available. So if you're not sure what to do, we get a lot of calls, and it really is dependent on the culture of your hospital, how involved your transfusion services. But if you're not sure, is this a transfusion reaction? Should I stop the transfusion? Or I don't understand, does my patient need washed products? You can just call the medical director. You can call the blood bank, ask to talk to the person on call, and they'll be able to connect you with someone. And depending on how big of a program, like our program has a resident on call, a transfusion medicine fellow, and then an attending. And it's pretty big. And some people don't have that. It's a medical director who's off site, but there is someone who's available at all times.
Awesome. Well, thank you again. It was a wonderful night. I learned a lot, like I said. And it sounds like we should bring you back because there are a lot of other transfusion reactions that we really need to talk about.
Yes. And I know that trips up a lot of people on their board questions, so they love to ask those questions.
And that way, maybe we can get some more pediatric residents get interested in maybe doing transfusion medicine, huh?
Yeah, I will also put a plug in that a lot of people don't realize that transfusion medicine is one of the few fellowships that you don't have to be a pathologist to do. So you don't have to do a path residency. You can actually go in through pediatrics, internal medicine, anesthesia. So it's definitely a field that's growing. We're seeing more and more clinical people go into transfusion medicine. Previously, it was mostly pathology. And I think it's great because we learn from each other. And then we make the whole field much better.
Excellent.
Awesome.
Well, thank
There
you
go.
again.
It's never too late.
Yes.
Never too late.
Never too late. Well, you have a wonderful day. Thank you so much.
All right, thank you.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Hartley Lidsky, and our wonderful social media team, which is mostly Denise Cruz on X, Blue Sky, and Instagram. We also want to thank Dr. Tricia Wong, a pediatric hematologist and transfusion medicine specialist at Oregon Health and Sciences University, who suggested this topic and helped develop our script. So I've been Sam Mazer.
I'm Hartley Linsky.
And this has been Chris the Chew Manchu. Thank you and good night. And for those who've made it all the way to the end, again, you're going to be graced with a poem written by AI. This one's titled Rivers of Life. Crimson droplets carefully matched hold power that science has barely scratched. In pediatric veins so small and fine, transfusion medicine walks a careful line. Little bodies with volumes precise, each milliliter bears its own price. From preemie infants, fragile and new, to teenagers whose marrow withdrew. Red cells carry oxygen's dance for anemics who need a second chance. Platelets stop bleeding's dangerous flow when leukemia strikes its painful blow. Plasma's factors, proteins, and more help clotting cascades reach the shore, while granulocytes, rarely shared, fight infections that leave children scared. Volume, rate, and warming care, watching for reactions with vigilant stare. Iron overload from repeated need, a challenging bounce for those who bleed. From cross-match science to donor screen, each step ensures the blood stays clean. This ancient medicine, now refined, flows between strangers, humanity entwined. Have a good one, guys.